How are we looking now? I see Manu just popped on.
Hey, good morning, everyone.
Morning.
Just waiting for Gladys, but we could probably start, and I bet she'll join momentarily.
Okay. Well, good morning, everyone. Happy Friday, and happy to be with you all again. Why don't we start with roll call, and then we'll take a look at the agenda.
All right, so I will start with Courtney Witten-Rivera.
Here.
Good morning. Manu Chowdhury.
Present.
Jorge Ramirez Garcia.
Present. Good morning, everyone.
Good morning. Miko Montgomery.
Good morning. I'm present.
Good morning. Leona O'Keefe.
Present.
Stephanie Fitzpatrick for the record.
Present.
And Gladys Rivera. We do have a quorum, but let me see.
Okay.
So Gladys is not on yet. I can do staff introductions and then email her. I do want to note we will also be joined by Kirsten Isaacson, who is the Metrics and Scoring Committee's liaison to the Oregon Health Policy Board. She is the vice chair for the Oregon Health Policy Board, who will be joining momentarily. Then in terms of OHA staff, there's myself, Sarah Kleinschmidt, joined by Stacy Schubert, Allison Proud, Andy Parker, Frank Wu, Derek Renke, Katie Howard, and Carly Castaneda. Let me just see if Gladys has been able to join. Gladys is not on yet, but we do have a quorum. And as you start, Stephanie, I can email her to join us.
Okay, thank you, Sarah. Ashley, if we can go to the next slide with our agenda. So today, as always, we'll start with reviewing the consent agenda and approving the minutes from last time. As of right now, I don't think we have any oral public testimony, but we did receive some written public testimony. I think 3 letters particularly that we received. So hopefully everyone reviewed those. And then we're going to discuss the 2024 incentive measure set, the draft, as well as the results from the survey that we participated in, get some update information about the challenge pool, as well as discuss our next steps for selecting the 2024 incentive measure set. We'll take a break, and then we'll go over the review process in terms of the incentive measure set. And then we'll wrap up with some discussion. Okay. And so as we just click through the consent agenda, any questions or thoughts, any corrections that need to be made to the minutes from our April meeting? Okay. So not hearing it. Ashley, you can keep going slowly through the slides there until we get to the slide 9, I believe. Okay, so I'm not hearing any questions or comments. Can I get a motion to approve the minutes from our April meeting? Actually, if you can go back one slide, sorry, thanks. To approve the minutes from our April, from our April meeting, as well as the consent agenda.
I'll motion to approve the minutes and the consent agenda. This is Courtney.
Thanks, Courtney. Get a second?
I can second. This is Leona.
Thanks, Leona. And Sarah, can you take us through the vote?
Sure. I'll start with you, Stephanie.
Approve.
Leona.
Approve.
Miko. How do you vote on the minutes?
Shamiko and Sarah, you all are really low for me. I'm not sure why.
I will try something else. Is this better on my part?
Yes.
Can you
Okay.
hear me?
Shamiko, do you
Hmm.
you can't hear anything?
No. Wait, can you hear me a little bit?
Yeah,
That's better. When you come closer, I think it's better.
Okay. I'll just be really close today.
Did you approve the minutes, Shamiko?
I did.
Thank you. Jorge,
I approve.
Manu,
I approve as well.
and Courtney.
I approve.
That's unanimous amongst the present committee members.
Okay, great. Thank you. Any updates from Gladys?
Not that I'm seeing. Let me check one more time. No. So I think we proceed, and if she's not able to join today, I will connect with her after the meeting. And I know that folks, if they have to miss meetings, folks have been really great about reviewing the recordings of the meetings as well. So this meeting will be recorded, or is being recorded.
So as I stated before, we did receive written comment, I believe 3 letters. Do we have anyone who has signed up or asked to do a verbal comment?
We didn't have anyone as of yesterday. Allison, has anyone contacted you as of this morning? Or Ashley, has anyone sent anything in the chat?
I haven't gotten any requests.
We've not had any chats so far.
We have 2 minutes to stretch, just in case anyone joins. I would hate for you not to hear their public comment. 1 minute now. What can I tell you all in this 1 minute while we're waiting?
So I can say again, a huge thank you all for completing the survey. I know, everyone is really busy, and that packet is monstrous. It's an enormous packet, but really important information, but that's a lot to go through and reflect on. So just want to say thank you to everyone for, taking the time to do that and complete that survey. I think that's really going to help and inform our discussion today. Sarah, you have anything to add for our remaining 30 seconds or so?
I will say, in terms of the survey, I hope that committee members were able to look at the report that Allison had pulled together, because some members included written comment about why you made your certain selections, and I found those helpful. So if folks didn't have time to review those before this month's meeting, I'm hoping that you would have time to review them before next month's meeting. And now it is 9:10. So you could close public comment. Well, you could have one last call and then close public comment.
Okay. So any requests for verbal comments? And sorry, Ashley, you can go to the next slide, slide 10. But any requests for verbal comment?
I still haven't gotten any requests.
Okay. All right. Okay. So we'll move to the next slide. We'll close out public testimony. And so what we're going to do now is we're going to have Sarah's going to, again, kind of go over OHA recommendations for the 2024 incentive measure set. And then we're going to review the survey results and then engage in a discussion in terms of how we want to proceed. I think Sarah's also going to kind of explain a timeline, or is that later? I think that's going to be later. You talk about the timeline. But either way, we need to decide what we want to do for the 2024 measure selection. So Sarah, go ahead, and if you could remind us what the OHA recommendations were.
Sure. So if you can move to the next slide, please. And I'm going to go over these very quickly. They were in the survey that was sent to you all, but this slide just shows staff recommendations from last month, which were to carry forward all of the 15 measures that are included in the 2023 set into 2024. And then the next couple slides will be a reminder they were in the slides from last month. And I think I said, sorry, they were in the slides from last month, and they're about the social determinants of health social needs screening measure, in which we had recommended for that measure, if it is included in the set, that the component 2, which is quantitative, that the reporting for that quantitative component be pushed to 2025. And that is something that you all had voted on last month. And you said that if that measure is included in the set in 2024, that second component, reporting for social needs screening and referrals, will not start until 2025. So with that, those were our staff recommendations. So if you want to move, Ashley, we can go to slide 15, please. Thank you.
So 1 second, Sarah. Courtney has her hand up.
Yep.
Sarah, I had a quick clarifying question on the SUH measure, pushing out component 2. I realized that in the specs, it says for component 2 that rates 1 and 2 will be calculated in measurement year 2024. So we voted to push that out to 2025, but then rate 3 wasn't going to be added until 2025. So are we thinking, was OHA thinking we push that out to 2026 to follow the same timeline?
We'd have to have a conversation with you about it.
Okay. Yeah,
just,
I guess then bringing that to the table as something that we should probably discuss at some point.
Definitely. All right. So survey results, if you can go back 1 slide, please. So just to give a background on the survey, so the committee had asked for a questionnaire before this meeting to help with your discussions today. So that survey included 3 questions about each of the measures that are currently in the 2023 set. And those questions were, how aligned with the committee's working definition of transformation is that particular measure? And just a reminder, the working definition of transformation, it was included in the measure selection packet and in the survey, but it's also included in the committee's consent agenda at each meeting. The second question was on whether you agree with the staff recommendation to include the measure in the 2024 set. And then a third question on whether you think that measure should be included in the challenge pool. And we'll talk specifically about the challenge pool later. So 6 of the 7 current members were able to complete the survey, but I need to note that one of those folks did not complete it in its entirety. A report, as I mentioned earlier, with the responses from everyone is included in the materials for today, so that's on the website for folks who would like to review that. So today I will summarize the quantitative findings, but I do think it's important for folks to read through the written comments as well. So now if we go to the next slide. So first thing here, this shows whether folks agreed that a particular measure should be included in the 2024 set. And you can see that there was broad consensus that all measures should be continued, except for the cigarette smoking prevalence measure, which is, you can see that highlighted. There was 1 member who felt that that measure should not be continued. That might be something you want to discuss today. If we move to the next 2 slides, so I'll go over slide 17 first. Thank you.
Sorry, Sarah, sorry. Leona has her hand up.
Yeah,
Thank
sorry,
you.
regarding the last slide. So in my new role, I'm on a very steep learning curve and I'm doing a deeper dive into all of these measures and got a lot of feedback after the survey. So I just want to say I would be willing to move my vote from yes to no for cigarette smoking prevalence, but also for the IET measure to a no. So I would like to have time to discuss that once we get to that point. Thank you.
Thank you. And Stephanie, thank you for helping with the, when people have their hands up. I have so many screens I'm looking at and it's hard to see that part of it. So I appreciate that. Thank you. All right, and yeah, it's totally fine. It's folks have comments and questions as I'm going through these. So this slide then shows the survey results by transformative potential score. This question, as well as the question about the challenge pool, was on a 10-point scale. So 10 means lots of agreement and 1 meaning lots of disagreement. So if you look at this table, each row is a measure, and this is sorted by transformative potential score with those with the greatest ratings at the top. So you will see also that 4 measures are bolded. These are the 4 measures that the National Quality Forum has indicated are disparity sensitive, which from the way they speak about that, it means that they recommend that those measures be reported by race, ethnicity, and language. You will also note, though, that 2 of those measures, HbA1c poor control, as well as depression screening and follow-up plan, are sourced from electronic health records. So that means in Oregon, because of technical limitations, we actually cannot stratify those measures by race, ethnicity, or language. We don't have the data to do it. So just bearing that in mind for those measures. So then if you look, still on that slide, so if you look down that middle column on transformative potential, all measures are rated at least a 7 out of 10. So it kind of seems like you all feel like each of these measures are relatively in line with your transformation definition. But that said, there does seem to be a bit of a cut where 4 measures score over 9. And interestingly, all 4 of those measures are upstream measures, with the social determinants of health measure rated highest, but it's really pretty close amongst those 4.
Sorry, Sarah, Manu has his hand up.
Hi, Manu.
Yeah, thank you. Hi, good morning again, everyone. I was wondering if you can do a little bit of a deeper explanation around the inability in Oregon for us to do the stratification based off of real D for these 3 measures. What's listed here is that Oregon can't disaggregate, and I'm having trouble connecting why we can't.
So it's because, and it's for 2 of these measures. So it's for 2 of these measures that NC, the National Quality Forum, has recommended be stratified by race, ethnicity, and language. So there are, sorry, I'm going to take a step back. The 4 measures that are bolded, the National Quality Forum considers those as disparity sensitive, and they recommend, therefore, that they be stratified by race, ethnicity, and language. 2 of those are sourced from the EHR. And in Oregon, the data that CCOs are able to send to OHA is not member level. It is only in the aggregate. And because of that, we can't stratify the information that we receive. There was
so for my ability with my benefit of understanding with connecting of the dots, the meaningful language access is also, I think, an EHR measure, but we are able to, no, it's not an EHR measure. Okay. And how are we able to do that for meaningful language access then?
So I have not highlighted any of the other measures here for which we would not be able to stratify by race and ethnicity. I only called it out for the 4 NQF measures because it's recommended specifically that they be stratified in that manner. Any measure that we get that is based out of the electronic health record, we cannot stratify by race, ethnicity, or language. So for example, cigarette smoking prevalence is on here as well. We cannot stratify that by race, ethnicity, or language either because it is sourced out of the electronic health record.
But we can, because electronic health record collects race, ethnicity data into it. Any electronic health record has it. Sorry, go ahead.
Right, but the data that CCOs are able to send to us is not person level. So we can't, the only thing that we get is in the aggregate.
Okay.
There
was,
thank
you for clarifying.
And we can talk, I can get more information on that. There was going to be, I can't remember the name of it, there was a ton of work that was put in by Kate Longberg, who used to be with the Oregon Health Authority, around having an infrastructure system to be able to gather member level data from EHRs through the plans to OHA. And because of changes at the federal level, we could not do that.
Sarah, can I just provide just a teeny bit more context for Manu so he can kind of visualize it? So Manu for the EHR-based measures, which again, to clarify, are the diabetes, hemoglobin A1C measure, cigarette smoking prevalence, ESPER, and depression screening. So those four, the CCOs track data from all of their contracted clinic practices to get aggregated population level rates, essentially, that we then report back to OHA for those four measures. So while the EHR does have the member level data, we don't collect it from all of our clinics for reporting to OHA. And then all the other measures are member level measures where they're tracked via member level data through claims or charts.
Okay, perfect. Thank you for walking me through that. That was really helpful. Thank you.
Yeah, no problem.
And I should say, that makes me think, yeah, this raised confusion in terms of not flagging all of the measures for which we can't stratify by race and ethnicity. But that piece is something that we're pulling together to provide for you as you think through equity and looking at these measures in that way. That's certainly something that we would look at, is literally can you stratify by race and ethnicity, if that's the way that you would want to think about equity measures. And Kristen, I see your hand is up.
Thank you. Sorry. I too found that very helpful, Courtney. So thank you. I had one follow-up question. Is it correct then to assume that because of that is how the data is collected, that the CCO looking at that data could also not stratify by race, ethnicity? Okay, great. Thank you. Really appreciate that.
Yeah, no problem.
Courtney, can you say it verbally so folks can hear it as well?
Yes, so based on the way that the CCOs collect data from clinic practices before sending to OHA, CCOs are also not able to aggregate data by race, ethnicity, and language for the clinical measures, the EHR-based measure.
Thank you. And Manu, I see your hand is up.
Yeah, I have a follow-up question for you, Courtney. So I know that the four bolded ones have been noted by NQF to have disparity sensitive. And then the follow-up second point of that is that we can't disaggregate based off the EHR measure. I was wondering, from your vantage point, representing a CCO, of all the measures that are listed here, which are the ones that, based on information that the CCO collects from the providers, are not able or capable of stratifying based off of a real D?
I think that we would align from the CCO perspective with OHA's perspective on just the EHR-based measures are the ones that would be very challenging to evaluate by real D. I think that the chart review measure, so the timeliness of postpartum care measure, is a little different also, just because it's based on a sample size of our population. But in theory, we do have the member level data that we could review for those. And then all the claims-based measures would be the most straightforward.
Okay. Okay, great. Thank you.
Mm-hmm.
And I'll remind folks too, we have our annual dashboard, and that included disaggregation by race, ethnicity, and language. And you'll see there that we could do that for some measures, but not for others.
But the piece of the annual dashboard is that information is being fed in by the real D collected at the stage of enrollment. But then there's also collection that's being done at the provider level. And so, so there might be a disconnect between what's collected at the provider level versus what the CCO is then comparing up against the enrollment data. I just wanted to point that out in terms that there could be misleading or confusion on who identifies as what race and ethnicity in one form during enrollment versus how it may differ as it relates to provider level at point of care.
Yes, and I want to note on that we are working to shift the data source for our annual dashboard to the RealD repository that folks from our Equity and Inclusion Division had come and talked to you about a few months ago as well.
Jorge?
Just want to clarify that measure tag for health equity or inequity sensitive measures are based on the National Quality Forum assessment. And there are at least two leading criteria. There are health conditions that have high prevalence in race and racial ethnic minority groups, and also health conditions with large gaps, basically inequities. So that's why they're tagged.
Just pausing to see if anyone else has a hand up. All right, I like all the questions. And I have one more slide here before turning it over to Stephanie. Or actually, I don't. I take that back because the other slide is about the challenge pool, and you're going to talk about the challenge pool later.
Yes. So can we go back to, what is it, slide 16? To help start our discussion. It sounds like certainly cigarette smoking prevalence as well as the IET. I can start with the cigarette smoking prevalence. I was the no vote just because I think there's a lot happening. So there's been a lot of progress on this metric based on the data. You know, it would be great if we can get lower than 20%. I'm not sure we will, but there's also some policy movements happening in terms of the ban on menthol and flavored tobacco and things like that. And so, and that I don't believe has taken effect, and please someone correct me if I'm wrong. I did a brief search in terms of to see where that was at, and I don't think it's passed quite yet. So, so there's, you know, still some work to be done in that space. And I think with the ban, if it does come, I would certainly want to see the impact, especially in communities of color where flavored tobacco and menthol is heavily promoted. But I'm not sure having this as a metric is going to be beneficial, and if we're going to get any better than where we are for right now. And, you know, certainly maintaining the same list of measures sounds like it's going to be really helpful to CCOs. And I get the feeling, I don't work at a CCO, but I get the sense that they would like it even more if we removed one or two. So, so that was part of my reasoning for that.
Stephanie, that's helpful. I think one thing I also would call out that kind of aligns with maybe some of your reasons, or could be an additional reason for retiring it, is I know we decided to keep the set the same, or we discussed having that be our path forward with the 2024 measures, but cigarette smoking prevalence is not on the core set. So in theory, in 2025, we won't be able to have it as a measure, right? So that's right, Sarah?
There's actually a way that you could get at it with CAPS. You could get at prevalence, but I should tell you there are caveats to that. With what you would be able to get. One is that getting it from the CAP survey, the questions around smoking are only for adults. So they do not have adolescents. To Stephanie's point, I know that you had mentioned in this survey about not having vaping, et cetera. The way the questions are worded in the CAP survey, it asks about cigarette smoking or tobacco use. And so it may or may not include vaping, because it would depend upon how the person interprets tobacco, if they would think of vaping there. And then the other caveat to note is that the National Committee for Quality Assurance, which is the measure steward for those questions, is potentially thinking of retiring them. So while you can get at it now, we don't know how long in the future that would continue.
That's helpful. Thanks, Sarah.
Those are a lot of the same things that I heard as well, that we've really kind of reached the maximum of what clinics can do. They've really established the processes for asking patients about tobacco use, and are already doing what they can to intervene there. So we may have kind of maxed this out. And at the same time, vaping is really the big issue right now. And so, you know, Stephanie, I read your comments, you know, can this measure be altered to include the vaping? I think it could be, but then if we're going to drop it in 2025, a year is not enough time for anyone to make those big changes, which is unfortunate, but realistic, I think. And also, you know, the evidence around vaping is a bit mixed in terms of damage. I think everyone in healthcare feels like it is damaging, but I'm not sure how confident clinicians feel to tell patients vaping is definitely damaging and you should definitely stop. So it's a little bit of a kind of an uncomfortable place to, I think, force clinicians into, at least right now, while that data is still being firmed up. So I think we either leave it until it gets dropped when CMS core set is used, or we just drop it now.
Sarah.
And I just know we cannot change this existing measure to add in vaping based on where it comes from the electronic health record. And I do feel like I have to raise for you all that there had been conversations previously about retiring this measure, and there was a huge influx of public comment from local public health authorities advocating for the inclusion of the measure. And part of that advocating for the inclusion of the measure was that it's a CCO measure. It's not just about what happens in clinics, but there are things that CCOs can do to impact the rate, which don't happen in a clinic. So just doing that.
Jorge?
I hear the concerns about measurement issues, and I want to acknowledge them as I preface my comment that I am concerned from a public health perspective about losing focus and attention on smoking. Smoking from a public health perspective, it's classic example of how public health interventions are effective and can drive population health improvements, yet increase disparities and inequities. It has been documented that while those public health measures that shifted downward smoking rates did not necessarily do so in racial ethnic minority groups and low socioeconomic groups, creating wider gaps as before, because as a population level decrease in certain subpopulations drove it, it remained stable, if not increased, in racial ethnic minority groups with low socioeconomic status. So that is a concern of mine. I do hear the technicalities and important issues having to do with measurement and with possible retirement. I would be more in favor of reviewing the evidence stratified by age and by ethnic racial minority groups, age cohorts. It could be that cigarette smoking is still prevalent in adult populations and older adult populations, in which, again, interventions to decrease smoking and lower the rates of smoking would be effective. So I just wanted to share that perspective. Thank you.
Thanks, Jorge. Just really quickly, I see Leona Manu's hands up. I thought this was one of the measures that we can't do the real deep breakdown, or can we? Courtney shaking her head, no.
No.
So we wouldn't be able to even do this breakdown. I agree with you, Jorge. And again, because I think of how it's promoted, and again, the menthol, that's why I'm excited to see when this ban comes into place, the impact of that ban on menthol cigarettes, particularly promoted in Black and brown communities. But if we can't look at the data, that kind of limits us. Leona, go ahead.
Yeah, I really appreciate what Jorge is saying, and always like to see the data to help guide us. And I have 2 questions. One, OHA has a tobacco cessation team and they have a website. Do they have data statewide, even if that's separate from our metrics data that could be used? And then I'll pause there before asking my other question.
So we're looking at the Public Health Division actually had come to this committee because they were having these conversations when there was consideration of retiring this measure. It's either last year or the year before, and I apologize, I can't remember which, but we're looking to find the slides. And to Jorge's point, one of the reasons that it was not retired was because of when you look at not this measure, but you look at smoking prevalence and tobacco use prevalence by race and ethnicity using other data sources, there are very large inequities because of marketing to communities of color, et cetera. And that was one of the reasons also that it was not retired. So I'm trying to find those slides to be able to show you. And the other piece I do want to note is, so for this measure, there are 2 rates. So one of them looks at tobacco and one of them looks at cigarette smoking and what is incentivized is cigarette smoking. There probably is at least some vaping in the tobacco rate. So you could consider switching to using that as the incentive measure rather than focusing specifically on cigarette smoking.
Okay, and then while you guys find those slides, thank you for looking for them. I think my other question that came to mind as Jorge was talking kind of gets to a bigger concept across the board, which is, do we have to have a metric in order to know that CCOs and clinics will be working on something that's important for the health of the population? So if this metric goes away, do people think that that means that CCOs and clinics and public health will stop putting effort towards tobacco cessation?
Manu, unless anyone wants to respond immediately to Leona's question. No, okay, go ahead, Manu.
So, I've really weighed a lot of what everyone has shared. And initially I was kind of on board with the idea of removing it from the measure set. And then I reflected a little bit on how oral health fits into cigarette smoking, vaping, chewing tobacco, all of those things. And in 2018, the American Association of Periodontology, which are essentially the gum specialists of the mouth, directly or developed a gum disease diagnosis protocol that integrates the amount of smoking or the number of cigarettes smoked is directly related to the progression of gum disease in the mouth. And so the more cigarettes you smoke, the higher rate of progression of gum disease, and the higher with that then with the exacerbation of gum disease, then that creates tooth loss and tooth mobility. And then that of course leads to challenges with eating, mastication, and then that leads to nutritional deficiencies, along with a ton of other comorbidities that are really downstream to all of these things. I liked Dr. Rivera's comments around of trying to understand where that fits across different race and ethnicities, and also for follow-up commentary around what does this look like from a public health perspective. And then to Dr. O'Keefe's question, these measure sets are intended to drive for transformation. And even though we know that these things will still be going on in the background because cigarette smoking and discussions around it have been around much more than 2016, much farther back than 2016 when it was first added onto the measure set. I still feel as though that without a intense focus on it, we're just kind of not necessarily going backwards, but even remaining stagnant doesn't really drive the transformation that we expect to see within the care to the population that we have. Thank you.
And Manu, thank you for integrating oral health. You know, that's always a challenge. And so thanks for bringing us back to that.
I do want to go back to Leona's question. I just, I don't know if it's feasible or readily available to take a look at CCO by CCO performance on this metric. I know that doesn't exactly get us at the race ethnicity part, but I'm just kind of curious in terms of kind of areas and regions, what's going on this metric. But I want to get back to Leona's question about if this measure was retired, does that just mean that CCOs say, okay, well, we don't have to work on that anymore? That's kind of unfortunate because I agree it is a public health issue. But I'm just kind of thinking about, you know, in the near future, especially as these more structural measures get developed and added that are more upstream, some of these things that are still remain to be a public health issue are probably going to have to fall off the measure set at some point in time. Not wanting to suggest that they don't matter, but we also don't want to overburden CCOs and say now there's 25 measures you have to meet. So I am curious for those who work at CCOs, kind of what's the conversations about when you all are taking a look at the selected measures, and are there still measures that you work on that may not be included in an incentive program, but they are important to your region or your coverage area, and you continue to do initiatives in that issue?
Yeah, I can start with a response based on my experience and what I've kind of heard across the board. You know, as we talked about, I think it was the last meeting where Lisa came and presented the, you know, quality strategy for OHA, and we discussed that, you know, each CCO has quality strategies in place as well as performance improvement projects and a lot of other work that the CCOs do outside of the metric space that allow CCOs to be able to focus on some of these still very important public health issues that maybe are no longer included in the measure set, right? Another example of that is ED utilization, which is hugely important, but we used to have 2 ED utilization measures in the measure set, and we now have none. But many CCOs are still, you know, focused on decreasing ED utilization across the board. So I think, you know, from my experience, removing it doesn't necessarily mean that CCOs aren't going to focus efforts on it anymore, or communities aren't going to focus efforts on it anymore. But I do also know that anything that is in the measure set always has an increased focus for CCOs regardless. And I know OHA has said that many times before too, just to emphasize that, you know, the measure set really does drive change. And that's a very simple way to put it, but that's really what it does and what it's intended to do. So I kind of feel like torn a little bit. I don't think it means that CCOs are going to stop working on it, but I do think that there will be a little less emphasis on it. And then my last final comment on it is that my other concern is because it is an EHR-based measure, CCOs most likely may not all continue to collect that data from clinics if it's not a requirement as part of the measure set. So that's something just to maybe keep in mind. And then I also don't know, Sarah, if OHA has requirements to keep reporting on it. So will CCOs still have to report on it? It just won't be incentivized if we were to go about retiring it for 2024?
We have said publicly for anything that you retire, we will continue to track it for at least a year to see if performance declines. And yeah, I have other thoughts, but
yeah, I'm sure you do. Yeah, but just I guess to sum up, then maybe that's not as much of a concern, that the CCOs will still collect data at least for another year to report to OHA, and the committee can obviously monitor that data Whether or not we have the capability of adding it back in 2025 sounds like that's mostly a no anyways, but still good for us to evaluate for other measures as an example. So those are my thoughts. I'll pass it to someone else.
Thanks, Courtney. Go ahead, Manu.
So thank you for broaching this question. From the perspective of a DCO hat, I can really only speak to the oral health measures. And with these measures, particularly, for example, the oral evaluation for adults with diabetes, with being on the measure set, through Q4 of last year, we actually took our mobile dental van and made in-home residence visits directly for adults with diabetes who had not yet utilized their dental provider for an oral examination. And so if we were to hypothetically take off that measure set, there's not going to be any charge or push to drive for that highly necessary need in the community to mitigate these chronic conditions and issues like that. And so that's why I personally believe that by continuing the cigarette smoking prevalence measure will continue the good of what we're trying to do within the communities that we serve.
Thanks, Manu. Leona? Oh, go ahead, Sarah.
I'm sorry, Leona. I'm just, Ashley is working to pull up from the annual dashboard data from 2021. We are finalizing performance with CCOs for 2022, but so that's now up on the screen. Do you want, I can speak to this, but I know Leona has been very patiently waiting with her hand up.
Oh, I just was also going to give my CCO perspective for what it's worth. And I think it is similar to Courtney's, but without a doubt, these measures drive transformation and they drive a much increased focus on the topics. I also hear very commonly, it's not just CCOs, but the actual care, our healthcare worker team, they are overburdened by administrative stuff. And a lot of that comes from metrics. And that doesn't mean we shouldn't be driving the transformation, but to me, that means we need to make sure we're prioritizing what we want to look at and we're aligning with what else is happening in the state in order to minimize that administrative burden as much as we can. So I also am mixed about whether or not we should drop tobacco at this point, but just those are some of the bigger ideas that are going through my mind as we kind of struggle with this decision.
You want me to speak to this, Stephanie?
Sure, yeah, that'd be great. Thank you, Sarah.
So this shows performance on this measure from our annual dashboard, which we are finalizing and validating data with CCOs now. So it will be updated to have 2022 data, but we're working with CCOs on that now. And you can see, actually, Ashley, if you can scroll up a little further, and I apologize, I need to look at a different screen because that is not large enough for me to see. But I can see that you can see that the trend over time is decreasing, which lower is better on this measure. That is what you want to see. And that is the statewide, CCO statewide line at the top. And then if Ashley scrolls down, you can see by CCO, the performance there. And you can see the line in the middle is the benchmark. That was the mark from 2021. Bear with me again, because I'm sorry, I have to look at a different screen to be able to see this. And you can see that CCOs, the kind of the tail end and then to the larger end, their trajectory, and a lot of CCOs are, doing better than what that 2021 benchmark was. There were some CCOs a bit above that, so have room to improve in comparison to that benchmark. I think that's what I would say about this measure. I mean, it continues to decline, and I think the caveat that I would say, and decline is good, the caveat to that would be, I can't stratify this by race and ethnicity. And when we looked at other data sources of cigarette smoking prevalence by race and ethnicity, there are stark inequities. Oh, and may I guess posit one thing for the committee's consideration. So obviously that, the agency recommendation is to continue this measure, so take that with a grain of salt. But one thing that you might consider is, if you are thinking of retiring it, maybe continue it for another year, because there is going to be this shift in looking to the core set, et cetera, in the future. And it would also give time to maybe start some more formal engagement that we could link with our public health division that works on tobacco cessation around this measure, and conversations with them. And then also trying to maybe bring in some folks from local public health authorities and maybe do some problem solving on this together before you would maybe retire it or switch to a different measure in a future year.
Thanks, Sarah. It's really helpful. Leona, you had some comments to make about the IET.
Yeah, thank you. So I got a lot of feedback, without exception, that people are feeling the initiation and engagement measure would be better as a PIP, which is CCO acronym for a performance improvement project, and it's already been started as a performance improvement project. And there's a number of reasons for this. So basically, it seems like having an IET, and I want to preface this by saying that IET is really very important to me. Like, I've done substance use disorder treatment. I think this is tremendously important right now. But it's just, how can we get at that transformation in the best way? And it seems like the metric of it is not causing true transformation and isn't capturing the level of work and change in process that's going on in the background. And so the reasons for that, I don't know if people are familiar with 42 CFR Part 2. It's this federal level law that basically says, if a provider who treats for substance use disorder receives money from the federal government and the community knows that they provide this treatment, then they cannot release information about that person and their substance use disorder treatment unless there is a specific release of information signed by that individual. So the impact of this is that clinics can't share with CCOs who those members are. CCOs can't share with clinics who those members are. And this greatly impedes the ability to coordinate care, which is the whole point, care coordination organizations. So that's one huge hurdle that's at a federal level that I don't think we're going to be able to fix here. The other thing is that the framework of the metric is extremely rigid, right? It's like, I forget, 15 days and 32 days or something like that, which you have to pick something, right, to create a metric. But that doesn't necessarily equate to quality care for that person. It doesn't capture those transformational efforts. And because we can't share member data, by the time the CCO receives a claim, often 90 days out, it's already past that window, and the time for intervention to meet the criteria of the metric is gone, long gone. So the idea, though, of making this a performance improvement project is that still brings focus to this topic, but it focuses more on the actual system changes. So the efforts that are going on, interventions, processes, peer support, which we know is huge and doesn't get captured in this metric. And it allows more flexibility to adjust in front of the provider of what they need. And the PIP allows proactive change, whereas the metric, we're kind of stuck doing reactive because we don't find out about the person until we're already past that window in which they're supposed to be seen. So I think this comes back to the idea of alignment with other state strategies. So there is a PIP from OHA to the CCOs, but it's a separate department from our analytics team here. They're using different data reporting tools, so that's doubling the work for the same effort. And I would like to hear discussion recognizing the importance of IET, whether it might actually be more appropriate to have it as just a PIP, or both the IET and PIP, but aligning how that data is collected so that it's a bit more streamlined and collaborative. That was a lot of talking.
One thing, yeah, Leona, can I just address that last point?
Yeah.
So the way current legislation is, you can only use measures that are on the HPQMC menu, and we can't change those measure specifications. They are what, there's intellectual property considerations, and there's also just, that's what was approved by the Health Plan Quality Metrics Committee. So if it's not on that menu, it's not available to you all to use.
So at HPQMC is where that collaboration needs to happen with other committees from OHA to align things like what type of data is being requested. At least that's what I'm hearing.
That committee has been sunsetted though, correct?
Well, it's being considered by, it's on pause, and it's being reviewed by the legislature. I will say we do, you know, the data that is provided for the PIP comes from folks within health analytics. We are on the same broad team, and we do work very closely with Lisa Bowie, who is our quality improvement director, who works on the performance improvement project, the PIP, who unfortunately is not on the call today. But there is coordination, and we do look at this measure in relation to what is included in the PIP and how things are trending together or not. So I don't want there are conversations about this both here at the Quality Health Outcomes Committee, et cetera. But I apologize. I can follow up with Lisa as well.
So thank you so much, Leona, for sharing all of that information. I think that was really helpful. And I agree with a lot of it. I think, to be honest, I think this topic, I agree with you, is extremely important. And so I would be hesitant to consider retiring it. But I do feel like there are some concerns with the ability for CCOs to be proactive about addressing the measure in using data, right? Because of that time frame. So the 14 and 34-day time frame. So 14 days is when you have to have an initiation visit, and then the engagement visit is within 34 days from that initiation visit. So because of that, the initiation time frame is so short that it's really hard to use claims data to identify these individuals, and then do proactive outreach to ensure that the individuals are initiating treatment. So I will say from that standpoint, I agree. It is challenging. Sometimes I compare it to the DHS measure just because there is also a short time frame with that measure, but we do get data from DHS/OHA to be able to proactively outreach on those members. So it's a little bit different. And I think if there was any way to be able to do that with IET, that would be amazing. But I imagine that there are also issues with that on the OHA side as far as being able to provide us with that data. However, I do think that the PIP is helping put some structure around focusing efforts on, like you were saying, kind of more transformative processes and workflows where we're having conversations with hospitals and locations where those index episodes, those first initial set episodes are occurring, and then trying to work from there on processes around, how to essentially try and get those individuals to initiate treatment within 14 days. So having more of this like process plan as opposed to individual patient outreach. So it's just a different technique compared to, you know, where we've historically been able to do outreach on a member level with some of these other measures. So I think that that's been challenging, to be honest. But I do feel like CCOs are, you know, making steps forward to try and figure out other ways to address this measure without having immediate access to data before the time runs out, basically.
And I just want to be clear from a medical perspective, those short timelines, 14 and 34 days, make sense, right? We want people to get in quickly. You want to take advantage of the window when they're ready. So with that, I completely support that concept. It just, with the way the data is currently able or not able to flow, it's very hard for those interventions. But Courtney, yeah, thanks for pointing out some of the other ways that you see it being worked on.
Yeah, and I'm super grateful that it is a PIP. And I don't know if, you know, I think we've kind of had some alignment with measures in the past and some of the performance improvement projects, but I do feel like this is one that just needs like extra framework around CCO efforts. And so I think that it's great that it's a PIP. And I think it's okay that it's in the measure set and it's a PIP personally, but I do feel like it's a measure that is kind of more of a system level measure in a sense, where it does require more system level transformation and efforts compared to maybe some of the other measures that we, you know, would normally categorize as these like downstream measures.
I'll just say it was because we're in the loop and having conversations with Lisa Bowie, the quality improvement director. When it was shifted to a PIP, I think that was a big conversation with the CCOs about like, do you have it in both places? And I think the rationale was that it's a way to, what you were talking about, Courtney, give it some structure and also the importance of it to have it in both places.
Other thoughts or questions or comments about IET or any of the other measures in the set? Go ahead, Jorge.
Appreciate the discussion of the challenges, especially with measurement and with the realities of being able to capture WHP members in those time windows. I understand that has been a big challenge. It reminds me of follow-up care after hospitalization. Is really challenging. It puts individuals who work so hard to be able to capture individuals in those time windows. I think that speaking of that, the spirit of those measures are that it is a critical window. There are data showing that the longer the time frame, the lower the likelihood that the individual will engage in treatment. So that's why those time windows are built into the measure, because the risk of not engaging goes really high the longer the time from those events. So I really appreciate that. I think that I just like to underscore, this is a health equity sensitive measure. And it is one that if we were able to look at data by race and ethnicity, we would see stark inequities. Our rural populations are hurting with the opioid epidemic. And substance use, it's just a problem population-wide, but the consequences of substance use affect disproportionately racial and ethnic minorities. I would be in favor of including in both the PIP and the IET measure so that we can solidify and strengthen those efforts. Our state has made very serious investments in substance use in the legislature, behavioral health is one of the priorities of our governor. I think it is a time to problem solve from that perspective and increase and strengthen these efforts. With the caveats that, measurement, it is a big challenge. The technicalities and the realities of these time windows. So I would be more in favor of including it and then problem solving and how we take that to the target improvements and benchmarks. Thank you for the opportunity.
Thanks, Jorge. I have a question that's racking in my brain right now, and it might be particularly for Courtney and Leona, who I know work at CCOs, but if there's others that I'm misremembering, if you work at a CCO, I hear, certainly with the IET discussion that we had, even with the cigarette smoking, there's a number of these measures that require policy changes. So when I say policy, state, county, local level policy changes, it requires systemic changes. It requires multiple systems outside of healthcare, outside of the healthcare sector. And so when I think about this incentive program and these dollars and how these dollars are used by CCOs, I'm curious to the point in which these dollars are used to advocate at the policy level, to advocate at the community level, to build the infrastructure needed to make true systemic change. I've been struggling with that a lot, especially when we talk about upstream and downstream, just because these metrics to some degree only get us so far. And there's so many other sectors that need to be involved in this work to truly have upstream change, truly have structural change. And there might be some assumptions about how these metrics are worded that the systemic stuff will follow, or maybe it is happening and that's not visible to me. And so I'm just wondering, to the extent that CCOs are really involved in the structural components of this. There's racist policies that are out that exacerbate these conditions, diabetes being a number one. There's a huge, a nice paper on this about how there are literally racist policies that are related to the prevalence of diabetes and the experience of complications in marginalized and minoritized populations more than others. So that would just help me to kind of put this into context when we're thinking about upstream and downstream, but also in terms of, by us keeping this measure, is it truly going to be transformative and change things? Is it feeding into the system, or it's up to a couple of other sectors to step into this? Again, an example, the ban on menthol cigarettes and flavored tobacco. Do we need to wait and see what that's going to do, or keeping this metric really going to be the answer to improve smoking prevalence?
Stephanie, I think you're getting at something that I have really been trying to wrap my brain around over the last week. And so I appreciate you guys going on the learning journey with me. I think it's both. And, I think a lot of, well, I don't know how many, at least some CCOs have like government relational specialists who's interacting with the legislators. So that's one way. I think all CCOs are trying to partner with others in their community, whether it's public health or CBOs, and support them both through convening people and also through funds. So there's really cool ways for CCOs to fund a lot of these kinds of things. And so they are working through that. At the same time, what I'm trying to learn is where the boundaries are of what CCOs can do, what the state has to do, and what the federal government has to do. And not just where those boundaries are now, but where we can push those boundaries too. So I think, it's both. Like, we have to realize what we can do within this realm, but and what CCOs are really capable of and what they're not capable of, but also where we can advocate and support and fund and convene and all those things.
Yeah, I would definitely echo exactly what Leona said. I think a lot of CCOs have lobbyists and individuals that do work at the policy level. And then also additionally, like Leona mentioned, a lot of CCOs have, you know, funding support and collaboratives and things that are set up to really try and impact some of that system structural change also like at the local level that really honestly has just kind of increased in demand and focus within some of these system level measures that have been implemented, right? I think about the health equity language access measure. I know there's been a lot of work across all areas of healthcare on that measure and at the policy level. So I think that it's definitely a combination of factors and that there is work being done with some of these dollars and maybe also, you know, on the CCO side without the incentive dollars impacting that necessarily.
Thank you all. That was really helpful for me to hear that. So I'm doing a time check. It's about 10:12. And so, Sarah, I just want to double check. Do you want us to make a decision now, or you want us to talk about challenge pool first and then come back to deciding how we want to move forward with selecting the measure set?
I think you need to make decisions about the full incentive set first, because generally the challenge pool is pulled from that.
Got it. Okay.
And these and clarifying, these are just with you all, these are draft decisions. This is like, they're not choosing the final set today.
Yes. Yes. And I'll also just add, I don't know if Sarah, you want me to add this, but I'm going to add it. I think the sooner we make a decision about a draft set, perhaps the longer we have for the public to be able to review and make some comments about this. Longer meaning it's still probably a month until next meeting, but ideally if we can come away from this call today with, you know, making a motion and approving on the measure set to then be reviewed by the public, and then we have a discussion about finalizing in June. But I just thought I would throw that out. I'm not trying to pressure. Again, if we need more discussion, that's totally fine. But I know we've also been talking a lot more about community engagement, and right now, you know, public review and comment is our primary way. Certainly, there's going to be some efforts to engage the community in other more effective ways, but we certainly want to make sure we have that time allotted for that to happen. So does anyone dare? I see Courtney gearing up. I was like, does anyone dare make a motion right now?
I'm not prepared to make a motion, but I do feel like maybe we should vote on cigarette smoking prevalence. So I think I guess it feels like there's consensus to move forward all of the other measures. I know Leona and we've had some conversations around IET. So maybe just kind of sorting through that before someone makes a motion. Or voting specifically on cigarette smoking prevalence first, since that was the one that had a no vote.
It'd be helpful to summarize what we're doing. Is it that we are doing a straw poll to move this forward to the next meeting and approve at the next meeting, or are we trying to approve the entire set before we move to the quality poll?
Yeah, so that's what we need to decide. Do we want to make a motion and approve the draft measure set, so that then there's time for public review for us to then finalize the measure set at our next meeting in June? Do we want to continue and have further discussions, which means it will be pushed to approve the draft in June, and so things get kind of move forward? And what I'm hearing Courtney say right now is, can we resolve the cigarette smoking prevalence issue first, and then we can move to thinking about the full measure set in terms of whether or not we want to approve the draft per OHA recommendations, or if we want to make some edits to this.
I like deciding about cigarette smoking. Just, yeah, I think that'll make it easier first. And I would just say for me, I came into it a bit equivocal. I'm still a bit equivocal, but Sarah's point, if the OHA team can really connect with some of those other OHA teams and gather information and data and suggestions and concerns for us before making a final decision, I think that that would be fantastic. But it sounds like that would be like a year process, not the next month process.
Yeah. So yeah, to clarify, my suggestion was to keep it in the set for 2024 and then have have time for a more thoughtful process before you would, with more engagement, not just with our public health division, but with local public health authorities before you would retire it. I mean, we can bring you anything. I will just full transparency. Every measure has advocates. If you choose today to retire any measures, draft retire, you will get additional information on those, and there will probably be advocacy at your next meeting, right, when you would finalize that. That's just, every measure has advocates. So just, we can bring you more information at your next meeting if you choose to retire this measure now. But my suggestion was actually not that. It was not to retire it, but kind of flag it publicly as something you are seriously considering retiring in the next year, and then have a longer time to have some conversations with folks about that. That was my suggestion.
Yeah. And I'll say, since I am the definite one that's on the screen, and now it's recorded and it's on video, that I'm the one who voted no on this. I mean, I still feel that way, but I'm also willing to wait a year. It sounds like either way, this may not even be part of the measure set for 2025 because of the changes that are happening. So if there's already kind of a habit and an approach to collect this measure, I'm fine with that. And I certainly champion the idea of further discussions with public health officials about how to continue to support these efforts and initiatives, especially if it's going to be removed anyways in the coming years, no matter what we decide, just because of federal government, CMS decides. So I'm fine with keeping it in. And any other thoughts on the cigarette smoking? Okay. So further conversation or thoughts about the measure set now as a whole and the OHA recommendations to continue the 2023 incentive measure set and as the 2024 incentive measure set? Go ahead, Jorge.
It seems implied that the possibilities are to remove cigarette smoking and perhaps IET, but there's no discussion so far to add measures to replace a measure if one was taken out.
I haven't. Did you have any proposed, Jorge, to add any measures?
If some were removed, I would think about that.
Okay.
But I was frankly going with OSHA's recommendations to keep these set the same.
From my understanding, we're not going to remove cigarette smoking. I didn't get the sense that IET was going to be removed because it's something that requires also further conversations. It's already part of both the PIP and the measure set. So as of right now, I'm not hearing any measures to be removed. Just want to make sure I'm hearing that correctly. Okay. But are there any measures that we feel like need to be added? No. Okay. Okay, so I'm going to do something, but I'm slowly pausing. Okay. I'm going to make a motion that we approve OHA's recommendation for a draft. This is just draft 2024 incentive measure set, which is basically keeping the same measure set as 2023, keeping that for 2024 as our draft measure set.
I'll second the motion.
Okay. Any discussion before we go to a vote, or comments or questions? Okay.
Just thank you for the opportunity to learn and discuss and grow together.
Agreed, totally. Okay, Sarah, can you take us through a vote?
Sure. And I will start with you, Stephanie.
Approve.
Leona.
Approve.
Tamiko.
Approve.
Jorge.
Approve.
Manu.
Approve.
Courtney.
Approve.
So that is unanimous amongst the present committee members.
Okay, thank you. And thank you all again for that thoughtful discussion. Completely agree with Leona. I learned a lot. And I think this is an important step to get this information out to the public. And then we'll see, you know, what reactions are, what feedback is, and we'll certainly take all of that into account when we move to finalize a measure set when we meet next month. So great. Sarah, do you want to start the conversation about the challenge pool? Do you want to take a break now? That was a huge, that was a lot. We maybe start our break now and come back.
Yeah,
okay?
if I get a vote, can I vote break?
Okay. I think everyone, so 15 minutes, that puts us at what is that, 10:40? Okay.
Sounds good.
Okay, it's 10:40. People come back online. Okay, so Sarah, you want to walk us through the challenge pool as well as the survey results? Can't hear you. You still muted, Sarah.
Thank you. Yes, thank you, Ashley, for going to this slide. So the challenge pool. Now that you have a draft set, you need to select a draft challenge pool. But before you do that, these next slides, I'm going to go over a lot about the payment structure for the program, because the challenge pool is really instrumental in that. So please bear with me, but it is really important, I think, to understand these things in selecting the challenge pool. So on this slide, bear with me, my computer is glitching on me. Yes, it is this slide. On this slide, you can see the amount of money in the incentive program in each year from its beginning through what we will pay later this summer. And the amount of money for the program is decided by OHA, and it's dependent upon budgetary and other factors. And you can see that it has increased in many years, though there were some years where it has been reduced. You can see a big reduction in 2019, and in 2020, it was significantly reduced because funds were shifted from the incentive program to deal with immediate system needs at the beginning of the pandemic. So as you can see, and as you think about the challenge pool, and then as you shift from selecting the challenge pool to thinking about benchmarks, one thing the committee should really be aware of is that regardless of overall CCO performance, the entirety of the incentive program funds are paid out. So for example, there's an estimate about $300.8 million for the incentive program for 2022, which my colleagues and I are working to push out the door to CCOs next month. And however CCOs perform overall, all $300 million will be distributed. And the way that all of those dollars get out the door is via the challenge pool. If we go to the next slide, thank you. So the payment structure works in two phases. So there's phase one, and then the challenge pool is effectively phase two. And on this slide, I'm talking about phase one. So this is before the challenge pool. So going back and thinking about payment for 2022, where we have about $300 million for the incentive program, how much of that $300 million an individual CCO is eligible to earn is based upon enrollment. So a larger CCO with more enrolled members can earn more than a smaller CCO for similar performance. So for 2022, my colleagues and I were looking at how well CCOs do on the measures and benchmarks selected by this committee. And an individual CCO does not have to achieve all of the measures to earn all of its allotted incentive funds. They have to achieve 75% of the measures and benchmarks that you select. So if they achieve at least 75% of the measures, they will get all of their allotted incentive funds. And their allotted incentive funds, again, are dependent on the number of enrolled members that they have. If they don't achieve at least 75% of the measures, then their payment is incrementally decreased, like you can see in the table on this slide. So it's not all or nothing. So you can see as performance, if they don't meet at least 75% of the measures, say they meet 68%, then their payment moves down to 80% and 70%, et cetera. Those percentages on the right, it does shift depending upon how many measures are in the program, but you can see there is this incremental reduction below 75%. And then the funds that an individual CCO does not earn in phase one shift to and fund the challenge pool. And in the challenge pool, all CCOs are eligible for those dollars. And I'll go over that on the next slide. If we can advance, please. Can you advance to the next slide, please, Ashley? Thank you. So we OHA shifts any of these unearned funds from phase one to the challenge pool. So that's the first dot on this slide. And historically, the challenge pool has been 3 or 4 measures drawn from the full list of incentive measures chosen by Metrics and Scoring, but you could technically use any of the measures from the Health Plan Quality Metrics Committee menu. So that's the second dot. The challenge pool, it provides CCOs an opportunity to earn back all, or in many cases, actually even more of those unearned funds from phase one. And you can see on this slide that the amount of the challenge pool has ranged from a low of 1.25 million, and that was in 2015, to a high of 45.8 million in 2019. And in theory, the challenge pool could be zero if all CCOs met at least 75% of the measures in phase one. So in 2015, we were close to that. In all but 1 year, the exception being 2016, the majority of CCOs have actually earned above their initial incentive program allotted phase one funds because of the challenge pool. So I'll show you how that works on the next slide. Next slide. Thanks. So this shows payment for 2018 as an example. 2018 is not special. Full disclosure, the reason I use 2018 is because of some formatting things with our reporting. It was the easiest thing to pull in here for you to look at. So please don't worry about the fact that it's 2018. There's nothing special about 2018. And I don't expect you to be able to look at all of this. We're going to break it down over the next slide. So if you can advance, please. So if you look in the lower right-hand corner, it shows payment for 2018. And the full amount in the quality incentive program was about $188 million. So that is what is available to earn from the incentive program across all of the CCOs. If we advance to the next slide, then you can see, if you look at the blue columns, so this is the phase one distribution. And if you look at the bolded column, you can see that 12 CCOs met at least 75% of the measures. And so they each earned 100% of their allotted incentive program funds. Now, remember that that exact amount that they can earn is based on their membership. So that means that the 3 remaining CCOs did not earn all of their allotted funds in phase one. And you can see that that ranges from 60% to 70%. So that means that we did not pay out all 188 million in phase one. Instead, we paid out, what would have gone for phase one is $174.5 million. So that left about $11 million for the challenge pool that you'll see if we advance. Thank you. So you can see that nearly $11 million here in the red columns for the challenge pool. There were 4 challenge pool measures in 2018. And unlike in phase one, challenge pool payment is per measure. And though again, CCO membership size does factor in. So you can see here how much in additional funds CCOs earned from the challenge pool for 2018. So that was anywhere from about $100,000 to almost $4.3 million. And it should be noted that all CCOs can earn challenge pool funds, both those that earned 100% of their phase one funds, meaning they achieved at least 75% of the measures, as well as those who didn't. If we go to the next slide, you'll see how this all kind of pans out across the CCOs and across these 2 things. If you can advance, please. Okay. So you can see here that the CCOs that met 75% of the measures in phase one, so that's the bolded in blue, ended up earning over 100% of their allotted incentive funds after the challenge pool measure performance was considered. So look at the blue in bold, and then I'm not sure what color that is, like orange in bold in the total, and compare those. And the CCOs that did not meet at least 75% of the measures also saw a bump after the challenge pool dollars were redistributed. And we saw this just happens in every year. So an example in 2016, a couple CCOs earned 70% of their funds in phase one, but after the challenge pool reallocation, it bumped their earnings up to 82%. because they sufficiently improved quality on the challenge pool measures. And we see that in other years. So that's the payment structure and why the challenge pool is important. It can be both protective of any funds that aren't earned in phase one, because some of those can be earned back. And it can also provide additional bonus funds for CCOs that do well in that first phase. And I have some more slides, but I'm going to pause on this piece first to see if there are any questions. Not seeing any. So if we can advance to the next slide, this just shows your current challenge pool measures for 2023. So child and adolescent welfare visits, which is one of our kindergarten readiness measures, immunizations for adolescents, preventive dental and oral health services with the 2 age groups, the younger age group part of the kindergarten readiness measurement strategy, and then timeliness of postpartum care. And bear those in mind when we look at the next slide, which has the survey results. And so here, this is the same survey results table that you saw earlier today, but it's now sorted by the last column on how strongly you feel each measure should be included in the challenge pool. And you can see here that there's a much greater range on challenge pool inclusion versus transformational potential. So the measure you'd least like to have in the challenge pool is the cigarette smoking prevalence measure with a score of 2.8. And the one that you'd most like to have is postpartum care with a score of 8 out of 10. And it was kind of interesting to me in looking at these that none of the upstream measures those 4 that you could put as most transformational, none of those were in the top 4 here. So what made it into the top of all of the current, what made it into the top was all of those current challenge pool measures from the previous slide. Except for adolescent immunizations, you can see that flipped with childhood immunizations. So it seems you generally, in terms of the challenge pool, you generally like the current challenge pool measures, and maybe you could consider potentially continuing those into 2024, maybe swapping out the immunization measures, or you could consider having both immunization measures, but that would bring you to 5 measures in the challenge pool. And I will note that that is more than has ever been in a challenge pool previously. And thinking about how you're going to make these decisions, I'll just go to my last slide before we'll get to discuss around all of this. And this just shows different approaches that you might take in choosing the challenge pool measures. So in terms of that, you could go by transformative potential from the survey, which the survey that you took, it was a lot of those 4 upstream measures. You could include the 4 disparity sensitive measures from the National Quality Forum. You could assess those which you think most align with the community health improvement plans priorities. So the community health improvement plans, CCOs have to update those every 5 years. And there was a summary matrix that the committee had looked at last year that summarized the 2021 plans. And this is the most recent information that we have. And then the notes on this slide on the right-hand side, you can see at a high level some of the priorities that stood out across the state. You could also pick a theme. You could look at measures impacting kids, or measures about access, or measures about diabetes management. And that has been done in the past. There were a couple years where the challenge pool focused on kids while the committee was waiting for the kindergarten readiness measurement strategy to be developed. Or you could do some combination of this, or that you may have other creative ideas. But these are just some thoughts for you to consider. And I'm happy to answer questions.
Thank you, Sarah. Any questions for Sarah, or questions in general, and thoughts, comments about the challenge pool? So I'll just say I have 2 thoughts. One, I believe it was last year, we received some public comment about, and really a request to maintain the challenge pool, to not switch it up every year, change it up every year, to give CCOs a chance to meet the challenge, to have an opportunity at those additional dollars. So that's certainly going through my head, and also just the approach we just went through with drafting the overall incentive measure set. And then thinking about the written comment that we received in terms of the immunizations, and that it looks like there's an overall decline period across the state, and certainly for various CCOs. And I don't know to the extent that is necessarily pandemic related, culturally related, in terms of just concerns about vaccinations and immunizations and things like that. And so I'd love to hear if anyone has any thoughts about that. But it certainly makes it extremely challenging to push CCOs to try to push for immunizations if it is becoming if there's a pushback on it from a cultural perspective. So, but we'd love to hear thoughts on that.
I think that it's a little bit of both. I think some of it is recovering still from the pandemic, knowing that the time frame for the immunization measures kind of goes back further, right? Thinking about when you need to start the series of vaccines. So I think the pandemic is still definitely having an impact. I know we haven't been able to see 2022 CCO level performance data yet, but I know when we looked at 2021 performance across the CCOs, those were the two that were most dramatically impacted and had declined between 2020 and 2021. So I think, it would be worth looking at the performance for 2022 if we could see that at some point in the near future. But I think that some of it is also cultural. I know there's a lot of vaccine hesitancy that is still very much in place, maybe was exacerbated by the pandemic. I'm not totally sure. Maybe Leona or someone else could speak to that better than I could, but I do think it's a combination of factors is what we've been seeing kind of across the CCO space.
Yeah, I agree. I think it's definitely multifactorial. I think there was a loss of child checked availability during the pandemic, which led to falling behind in vaccines. And it's hard to catch up because there still are not adequate appointments available in primary care, whether it's pediatrics or family medicine. And I think there has been an increase in concern about vaccines in general from parents and caretakers. And so that needs to be addressed as well. And that's not going to be a quick turnaround, particularly since that usually involves one-on-one trusted relationships and conversations. And that's what we're lacking right now with the highly impacted medical system. And I think that's more true. Well, the data shows that's more true in the rural areas, that they were more heavily impacted by a loss of staff than in the larger cities. So I think those letters that we've received for public comment, we definitely need to keep in mind. I think probably more so when we get to the benchmarks and how we're setting those.
Yeah, I think one thing I would add, Leona, that just to reiterate what you mentioned about catching up on vaccines, I think that's something that we've heard from our providers is that potentially these kiddos are actually getting all of their vaccines. It's just past the deadline because they're on all of these delayed schedules. And so I think that's something that we've heard from our communities, pushing back on the time frame. And I'm pretty sure we've discussed that. The committees before us have discussed that. And I don't think that there's wiggle room to change the time frame. Yeah, Sarah says no. So I have not wanted to waste efforts on having that conversation again, but I do feel like it's important for us to keep in mind with, benchmark setting. And I don't know if we can look at data, Sarah. I don't know if Rex or anyone can bring data on the number of individuals, for example, for the childhood immunization metric that met the metric timeframe versus those that actually did receive the vaccine series, but perhaps delayed. If there's any way to pull that data, that might be very interesting to look at.
Yeah, I have heard the exact same thing. And yeah, we've talked about it before, even if you miss the deadline by a week, it doesn't count because that's the way it's set at the federal level. Oh, darn, I had another thought. Oh, this getting into where there are some things at the system level that can be improved on to help with this, but is kind of beyond what we can do on this committee. It sounds like there's also issues with alert. And so, you know, updating that, getting it caught up technologically, making sure the vaccines are being entered, or maybe making it easy for crossover between EHRs and alert would really help capture vaccinations that have been given, but just aren't entered into alert as well. So there are kids who are caught up, just not based on the schedule being used for the metric. And there are kids who are caught up, but aren't being seen with an alert. So there are some faults to the data itself, but without a doubt, there's also a change in vaccination rates in the state.
Jorge?
3 points come to mind. One of them, the first point is that we do have a theme of continuity to stabilize our system. Our healthcare workforce is hurting, and we're transitioning out of the pandemic. We just chose a measure set that it's provides continuity. And I do also recall the public testimony of the consequences of disrupting the challenge pool. So I would be in favor of that. The second point is that the immunizations do pose a big dilemma in my perspective. We do live in a state that it's an outlier, if you will, in terms of its immunization record compared to the national norms. I believe that we have lower immunization rates. Yet the pandemic just showed us how important vaccinations are, right? Vaccinations are a really important way to contain infectious, spreadable viruses. So if there's a lesson or a point to be taken away from the pandemics, it's about their importance. Yet there are very clear challenges, again, because of healthcare workforce and disruptions in engagement that you just all mentioned, that pose a challenge in terms of keeping up with those rates. So the third point is that in terms of health equity, I would be in favor if we had at least 2 measures, if not more, who had a health equity focus. We do already have one, postpartum care, which is a health equity sensitive measure. And I wonder if you all would consider adding at least another one. It is one way to incentivize health equity, a clear way to give it special focus and attention, which the challenge pool does. So I would ask us to consider having at least 2 measures that are health equity measures in our challenge pool. Thanks for considering that.
Thanks, Jorge. Do you have thoughts on which of the health equity measures? There's 1, 2, 3, 4. Is that right? Not, I mean, 4 enters an NQF. I know we also, the other upstream measures as well that are a little bit more structural, but is there any one in particular, Jorge, that?
Well, if we could go by the number of votes, it could be the one that received the highest number of votes in addition to postpartum care. Or if we go by disaggregation, then we could choose, I believe depression can be disaggregated, or IET can be disaggregated. And the EHR measures, we still have to work through those challenges that we just discussed in the first part of our meeting.
I'll list in the chat the 4 NQF disparities, sensitive measures, and then there's obviously the meaningful English health equity measure locally developed.
Sarah, can you put an asterisk next to the 2 EHR-based measures just so we have those? Thank you.
Can you actually, Ashley, can you move to slide 28? That way we can see the survey results. We can see the ones that are NQF.
Or do that. That's so much easier. This is why Dr. here.
And just a note here too, I mean, right there, so there's the transformative rating, and then there's, should it be included in the challenge pool or not? And so I'm looking at the transformative rating here, the top one being the social needs screening and referral, I think, followed by the health assessments for children in ODHS custody, and then the equity meaningful language access, I believe. My assumption, and please correct me, group, if I'm wrong, my assumption of why some of these structural kind of midstream, upstream metrics were not rated highly to put in the challenge pool, because I think it's still in development. CCOs are really still in development of being able to meet these metrics. And so I think there was a concern about maybe overburden. But please correct me if I'm wrong, but that's how I was thinking about it, is that because there's so much structure that needs to still be put in place for certainly the meaningful language, even the social determinant screening and referral, but others.
Yeah, I think the SDOH, the social needs screening and referral, and then the social emotional health metrics are in phases of being attestation based. And right. So they're like, you must meet requirements, you must do these activities, and then you meet the measure essentially. The meaningful language access measure was attestation based, and this year was the first year we have a target for it, right? So this does actually track performance data. And then the DHS measure does track performance data and always has, and actually was in the challenge pool for many years. And I don't know why others didn't vote to include it, but one of the reasons why I didn't, while I think it's an extremely important measure, and I do love that it crosses all realms of physical health, behavioral health, and oral health, we as the CCOs have performed very high on the measure for quite some time. So that was part of the reason why I didn't include it necessarily. But I do think it's extremely important, and I would be open to including it. But anyway, that was my context.
So I guess let me start here. Is there a measure we would like to remove from the challenge pool before we entertain a measure that we would like to add?
Well, I think the one thing that it sounds like maybe there's consensus on is keeping postpartum care. So maybe we start there. Does everyone feel comfortable keeping postpartum care in the challenge pool measure set?
Yeah. Do people feel like we should relook at immunizations for adolescents and either take that out or swap it with the childhood immunization status?
Sorry, Stephanie, can you repeat the question?
Should we consider taking out the immunizations for adolescents? Or swapping it with the childhood immunization measure?
Or removing all immunization measures altogether.
Yeah.
Thank you, Sarah. I was just going to ask you to put those in there. Thanks.
Oh, sorry. Can we go back to 27? Ashley, sorry.
Can we be reminded what the 2022 challenge pool was?
I can't remember off the top of my head, and I should. Give me a moment, and yes, I can find it for you.
It was preventive dental, well-care visits, meaningful language access, and system-level social emotional health.
Thank you, Courtney.
You're welcome.
Courtney, can you type it into the chat? Oh, maybe there is no chat. Can you just say it one more time and I'll write it this time?
Yeah, I think OHA is going to send it in the chat, but yeah, it's preventive dental and well-care visits. Those are the two that are still currently in it, that were in it in 2022. And then the meaningful language access to healthcare services measure and the system level social emotional health measure. Sarah, do you know why the committee voted to remove the two system level measures from the challenge pool measure set between 2022 and 2023 by any chance?
I think, so a lot of that was focused on the kindergarten readiness measures, right? Previously, you had those in there as well as in meaningful language access. My memory is there was conversation about wanting to have something broader in there. And I know there was concern about like not wanting to just add additional measures, and folks were really interested in immunizations, or at least last year in adding immunizations for adolescents, particularly given the pandemic, and they didn't want to add without taking something away, because otherwise it dilutes the challenge pool.
That's helpful.
I thought there was something too about for the meaningful language and the socio-emotional, and that's what I meant by it's in development. So even if it's, I know for meaningful language, we've now set a metric for that, but there's so many issues in terms of getting the right list, being able to verify how things are recorded. I think there was a concern about how can we then tell people to perform in a certain way and or make this an additional challenge when there's all of these different barriers that are not necessarily on the health system side. So that's what I recall too, that there was, and I think with the social and emotional, things were still being kind of put in place in terms of community-based relationships and thinking about the resources that, again, how could we, like, yes, you should be doing this anyways, and it's still part of the incentive measure itself. But that's just what I recall.
I remember similarly, Stephanie.
I'm curious if Manu has any thoughts about keeping preventive dental in the challenge measure set.
Definitely, without a doubt. I believe that preventive dental needs to be in the challenge pool set. And one of the main reasons why is because I personally view that oral health is a social determinant of health. The more that we can provide oral health access to anyone, or and especially to the younger populations, the more likely they'll achieve a lifetime of oral health free of any dental disease. And then, as what we already know about comorbidities associated with gum disease and Alzheimer's disease, gum disease, and loss of teeth for dentures, and gum disease and diabetes and all those other points of it, the more that we can be as upstream as possible in order to address and take care of it, I think that will help have better health outcomes down in the future. And then the other piece of this, why I think it should be included in the challenge pool, is because the utilization levels of dental care have not rebounded back to where they were pre-pandemic. And there's been a lot of reasons for that. You know, there's been Oregon OSHA rules that had prevented, you know, the amount of people in a waiting room, for example, or prevented mobile dental vans from going into schools to provide these assessments that drive for greater prevention, because of all these challenges around this idea, which is true at the time, which is that COVID is a respiratory condition, and anything dealing with dental creates these aerosol generating particles that can then cause more spread. So I think to assist rebounding the utilization of dental services and dental care, particularly with our most underserved Oregonians, tied back into this idea that oral health is the social determinants of health, I really fundamentally believe that by having preventive dental for the kiddos is why we should continue in 2023 as a challenge pool. Hopefully that was helpful.
I'll also say that I have practiced outside of Oregon, and oral checks and applying fluoride were a core component of well-child checks in the primary care setting. And at least in my area of Oregon, that is not the case. And I was pretty surprised by that. And so I think it deserves some really close attention, because just applying that fluoride is such a simple, fast thing to do that really does prevent a lot of problems down the line. And I think gets to that oral integration, right? Because if there are tooth problems that need a dentist, then that referral can be placed right there and then.
So not to be too forward, but what I'm hearing is postpartum care and preventive dental are likely to stay in the challenge pool as a draft. How are we feeling about immunizations and well care visits? And again, entertaining and also remembering Jorge's suggestion of considering another transformative, highly transformative measure that we may want to include.
I was looking back last year through our minutes to see why we chose immunizations for adolescents, and in it, I don't know if this is the reason, but it looks like when we were given the data for the draft set, they gave us a list of the 2020 average percent distance to the mean, and immunization for adolescents had the highest at 20%, almost double what any of the other measures were. So I don't know what the data shows now, and if that should factor into our thinking.
I don't have more updated data with percentage distance to the mean.
Can we come back to immunizations and talk about well care visits? How do people feel about that one? That one's been, I think, right on the list for a few years now.
I feel like I need more information. I mean, a year has passed since we've reviewed these, but I have no additional data, which I find a little odd. I'm like, I know there's data out there, but what has changed? Have things improved? You know, I know anecdotally about all of these, but I just feel like that's not a way I want to go about making a decision. Yeah, Sarah, I see your hands raised.
Yeah, so we are still in the process of validating 2022 data with CCOs. So the payments will go out next month, which is part of why when we think through your benchmarking and your benchmark recommendations, we won't have the agency's recommendations to you all until July, because we need to go through those final validated data. But we don't have validated data yet. We're working through that, and we know that claims come in at different times in the year. And we've had some conversations previously about looking at data in the middle of a measurement year, and that not necessarily being accurate, because we do get claims later in the year that will change those rates, in addition to the validation process that we go through every May with CCOs.
So looking at the data from last year too, it looks like in the measure selection packet, it looks like well-child visits improved from 2020 to 2021, but the rate was still below the starting measurement year of 2018, right? So just looking at that with the data that we do have, it looks like it's still below where we started, but we are making progress, which is good. It does seem that CCO performance varies, or it varied a lot in 2021, though, based on the dot graph that OHA put together for us.
I can say for well-child visits, the preliminary data that we're still validating for CCOs, validating with CCOs for 2022 does show that there's still a lot of work needed on that measure in terms of pulling out of the pandemic.
That's helpful, thanks, Sarah.
I will say that child and adolescent well care visits do add a lot of primary prevention value. It is primary prevention since it's a well care visit, and it is younger people, and number of issues can be prevented or detected early. And as a whole, this looks like a challenge pool that places a premium on primary prevention.
So I'll take a slightly different route. Going back to the list of the ranking by transformation and thinking about health equity as the long-term goal, is there a measure that we feel like should be considered or reconsidered to add to the challenge pool? Let's start there, and then maybe we can work backwards in terms of what would need to go to make room for that measure.
I have been noodling around on the inclusion of the social emotional health metric. I personally like to have a challenge pool that has behavioral health, physical health, and oral health all included. And I feel like the social emotional health measure was ranked as, was it the highest? Did we rank it the highest? I think it was the highest ranked transformative.
No, it's high, but not as high as the ODHS one for the challenge. Okay. Yeah.
Anyway, it's one of the system level measures that we all ranked pretty high for transformation. So there's alignment from that side of things. And then it's also incorporates behavioral health and also integration practices. So this year, the CCOs are working on asset mapping for the integrated behavioral health, or sorry, integrated PCPCH practices that have behavioral health services. And so there's, that's also partly why I ranked it very high for transformation, because there is integration there as well. And it's focusing on a very vulnerable population. So I would be interested, if we do want to align with some of the ones that we voted out on as highly transformative, I would be interested in adding that into the challenge pool. But I'm not sure which one we would remove in its place. So there's that.
Go ahead, Manu.
I really like Courtney's idea of having a sort of a bundled measure in the 2023 challenge pool. I don't know if bundle is the right word or global, whatever word that you phrase that should be more appropriate to use. My understanding of the social and emotional health metric was that oral health was not a part of it, but maybe Sarah could shine a little bit more light on that.
Yeah, I mean, I think it really is more of a behavioral health measure, right? It's looking at the social emotional health services for kids, both from healthcare providers as well as outside of that. So in that sense, it's not focused on oral health.
Yeah,
and that's okay. That's okay. I think. Sorry, Courtney. I think from a humanistic perspective, especially as we're exiting the COVID pandemic, I think the more the more evaluations that are done, particularly in the children population, the better understanding we're going to have for the future of kind of getting back to normal and kind of growing up and away from the experiences that we all had with the COVID pandemic.
And Manu, I just wanted to clarify when I mentioned the framework or kind of the mindset I have around the challenge pool is including at least a measure in each healthcare realm, right? So having a dental measure, having a physical health measure, having a behavioral health measure. And then if there are ones that have, crossover, like the social emotional health measure, then that's great too. So just to clarify, I wasn't thinking that we would include a measure that encompasses all three, which there are a few that do. The DHS custody measure is one of them, for example. Sarah?
Yeah, definitely. Thank you for clarifying that. That helps kind of understand. But I think, again, from a humanistic perspective, I think the right thing to do would be to actually include that as a challengeable measure, supporting what you initially had suggested.
Sarah?
Yeah. So reflecting on the ODHS custody measure and how it's been in the challenge pool previously, but all CCOs are doing well on it generally, right? And it's such we're talking about the most vulnerable kids in our state. And you're talking about being creative. You could consider including that in the challenge pool, but you could change the spec. We can do that. It's an OHA measure. Right now, CCOs get 60 days for the assessment, but actually the American Academy of Pediatrics recommendation is 30 days for the assessments, and that's actually in Oregon Revised OARs for ODHS. Their requirement is actually that the physical and dental assessments occur within 30 days. So that would be a way to focus on a vulnerable population and not have that be the threshold for the incentive program, but just in the challenge pool.
Go ahead, Leona.
Yeah, I just need some help with the social emotional health metric. It looks like for 2024, it's measurement year 3. And is it all yes, no, can it pass, fail? And if so, how does that impact putting it into the challenge pool as opposed to just the quality pool?
So that measure has previously been in the challenge pool. So it would be the same way. So that this next year, 2024, is the last year that it would be a structural measure only. After 2024, it will shift to a quantitative measure. So, they're in terms of your benchmarking decisions, right? If a CCO passes that measure, meaning they attest to all of the required components in the measure, which means they review data provided by OHA, they have to do additional mapping of assets, they have to work with their community partners to review all of those things, and they have to create action plans with communities. and move forward on those actions. And if they attest to doing those things, then they meet that measure. And so they would, with that measure, because of it being structural, if they meet it in phase one, then they would meet it in the challenge pool. So what we mean is that benchmark for that type of measure is different. It's attesting to the activities required by the measure. Does that help? Does that answer your question, Leona?
Yeah, half of it. So how does, I mean, if it's just a pass fail or an attestation, I guess by putting it in the challenge pool, we're saying we really want you to complete these asset maps and be ready to go for the next year when you're doing the work that's all based on this foundational asset mapping and all of those things.
Was there an answer to that? Did I hear a yes? The Leona is correct. Okay, I'm sorry, I didn't hear the. Jorge,
yes,
go ahead.
Leona is correct.
Okay.
I don't have a different thread, so I don't want to interrupt or talk until Leona's question is resolved or discussion. But I'd like to be in the queue.
Oh, Sarah nodded yes, so I've got it straightened in my head. Thanks. Okay.
Well, one more, what's the word? One more consideration for health equity. Our draft measure set has 5 measures that have a clear health equity criteria. Equity, meaningful language access is culturally and linguistically appropriate services, and 4 measures that are health disparity or inequity sensitive. Puts us nearly about 1/3 of our measure set has from those criteria an emphasis on health equity. So I would just like to once again ask us to consider having at least 2 measures with a health equity focus, so we get to that 1/3 or more in our challenge pool representing health equity. We have timeliness for postpartum care. And then we're left with 3 measures: initiation and engagement and treatment to substance use, and diabetes and depression, which are EHR measures. But that those measures have been vetted to have health disparity and equity sensitive component with really hard criteria by the National Quality Forum. Or in addition, the equity meaningful language access measure certainly provides linguistic assistance to populations that would benefit from it and increase their access to healthcare. So I would ask us to consider that. Thank you.
Thanks, Jorge. I have 2 thoughts. One, I like the idea of putting the meaningful language access back in the challenge pool. The reason why I say that is because, you know, we've had our discussions with the, I'm going to forget their correct title, but the diversity and inclusion group. You know, I agree. Having access to care, the right care, and in a way that's meaningful and understandable to you is a right. And even given the barriers and the limitations that I mentioned before about lists being incorrect and not updated and all of the data capture and everything, the idea of putting it back in the challenge pool to push to figure out these barriers and get them and remove them and figure out innovative ways to remove them, so that not only are we capturing the data, but people are getting the care the right way and the way that they understand it and that is meaningful to them. So I like the idea of adding that one back in. I also like Courtney's thought about having a behavioral health. I've been saying for years, and I always get shot down, the depression screening and follow-up. And the reason why is, and I'm a clinical psychologist by background, and the reason why is that there's a lot of focus on kids, as there should be, but we got to have caregivers for these kids. And those caregivers also have to be mentally and physically healthy. And so just throwing that out there as well. And we also see that there's clearly disparities in that metric, even though we won't be able to capture those disparities via Real D because of the way that the data is aggregated. And I hope that, given that this conversation is recorded, I hope that at some point systems start moving to figure out how to disaggregate this data. I don't think that can be an excuse forever. I think at some point systems have to change so that we can be able to break down data no matter what the source is, to be able to understand what's happening, to actually then advance health equity. But those would be the two. If we could add, and again, thinking about this health equity focus, either the meaningful language or the depression screening. And if that means that one has to be removed in order to do that, I would probably say immunizations, I would say to take that out.
Yeah, thanks, Stephanie. I generally agree with you. I was kind of looking at these bolded measures and using the mindset that I have around behavioral health. It felt like depression screening or IET were the best options for inclusion with, from the list of 4 from NQF. But then also thinking in my mind about the conversation we just had about IET with Leona, that maybe isn't the best move. Or it is, I'm not sure, but I like the idea of including depression screening and having that be the behavioral health focused measure. And I think I'm also torn about the immunizations for adolescents, because I think that there's a lot of, I think it's really important and there's a lot of need to improve performance on that measure, but I also want to be responsive to the public testimony that we received and kind of what we're hearing from providers and the communities related to just immunizations in general.
Just a couple of thoughts. I couldn't agree more that when someone goes in for healthcare, they need to understand what's being said. And meaningful language is critical. I'm also remembering that I think we set the benchmark really high last year for this year, which I think pushes the mark there. And so I still hesitate to put it in the challenge pool because of all of the other higher level things that have to be improved upon before saying that the CCOs and providers are fully responsible or majority responsible for making those measures come through. And with depression, again, completely agree that it's hugely important, and it just seems even more important than ever right now. And part of me feels like it would be good timing to put it in the challenge pool because there's a lot more focus and funding coming down from the state level. And I'm also wondering, is that focus and funding lining up to really make a more robust system to manage depression this year? Because screening is really important, but that referral, that ability to give someone the care that they need now that you know that they have depression is really what we're after. And so is our system going to be able to receive that this year? And I don't know that anyone has the answer to that. That's just kind of what I'm wondering. And maybe, it's that back and forth, right? Is it the right time, but maybe it's not quite the right time, but putting it in there makes it the right time this year so that there's that extra emphasis. It's the usual tension that we have.
Others?
Just want to say thank you for giving full consideration to health equity sensitive measures. I think that it's clear, and I certainly appreciate and keenly aware, thanks to your discussion about the measurement challenges and healthcare system challenges. So it's not to dismiss those realities. Just trying to improve health equity, and work toward the goal of eliminating inequities toward 2030. Really appreciate the discussion.
And I want to just be really transparent. You know, as we discuss the health equity stuff, I think back to civil rights movement and saying, you know, this, like, it's not the right time. But really, if now's not the right time, is ever the right time. Like, you just have to do it. And so it's really, I don't know, I'm feeling very unsettled internally, saying, having that same discussion about the challenge pool, recognizing that these are the things that are really important. We need other things in the system to be in place, but can we push those things in the system to be in place? So just internally, it doesn't feel good to me to say maybe this isn't the right time, because I recognize we're way past the right time for a lot of these things.
And it's also the chicken or the egg, right? In terms of, do we need more psychologists and mental health providers of color trained and in the system, and then or do we go ahead and do it, and then that will then bring on, you know, availability, more resources and providers? But it's yeah, I totally understand that tension.
I will say that the CCOs actually, as their second statewide performance improvement project requirement, which Leona might already be aware of, is improving mental health access. So that is something that the CCOs are working on, and they also are required to have a health equity component included. So just some context there that work is happening at the CCO level, kind of just in a different way.
Got it. So doing a time check, we have about 18 minutes left in our meeting. Sarah, is the goal to be able to make a motion and approve a draft set for the challenge pool as well for the public to review before our next meeting in June? Or please tell us what the goal and what the timeline is.
I think ideally, so this is with the assumption that you select a draft set today, including a challenge pool, and then you would finalize it at your next meeting. And then we had talked about with your chairs using the next meeting to kind of kickstart benchmark selection, meaning you won't be selecting any measures. It'll be like a benchmark orientation where we would go over all the things, you know, that you need to consider, reminders about all of those things. And then you wouldn't, in July is when you would start selecting benchmarks, with the goal of finalizing benchmark selection by your September meeting. I was actually with colleagues, and Shamiko, to your point about more recent data, we are still in this validation process through the end of this month, and working to get those data finalized for 2022. But we would be able to provide you before your next meeting with the statewide rate and the ranges for each of the measures for 2022. So before you would make final decisions, you would have more recent data to be able to look at, that, if that's helpful. But yes, to answer your question, Stephanie, ideally, I think you would have a draft challenge pool set that you would select today, and then be able to reflect over the next month before finalizing at your June meeting.
is it possible to choose a draft set and say that, so like we pick 6, but say we're actually narrowing it down to 4. We just want more information, but these are like the 6 contenders that, and 2 are going to, you know what I'm saying? Like, I feel like to pick the 4 right now, I'm just not quite there yet. Because there's a couple that I would like more information and to think thoroughly on, but I don't want to choose 6, obviously.
There's nothing stopping you from doing that. And the other thing I will say is you could, I think you need to finalize the full set at your next meeting. If you needed to take another month to finalize the challenge pool, you could do that. I'll just note for you all that that does push into some of the time for your benchmark conversations. But yeah, what you're talking about, Shamiko, you could do that. And when we send this out, we could say that this is the kind of short list of challenge pool measures, and they'll make final decisions in June or what have you.
Yeah, I like that idea, Shamiko. I was kind of thinking the same thing because I want to like socialize them and get, you know, input and public testimony on some of these measures, specifically immunizations, actually, and then even depression screening, since that hasn't been in the challenge pool recently.
And I think it also allows us to think about what the right number is, because it doesn't have to be 4. It could be 3, it could be 2. And so allowing the public time to respond and say, these are our top 3, or could you just do 3, or could you just do 2 for us? Because it's just such a burden. So that'll be helpful as well. So I'm kind of hearing that we keep the 4 that are that from last time, and we perhaps add depression screening and follow-up plan. And I know there was some discussion about meaningful language access. That would take us to 6, but please tell me if that's not right.
Yeah, I personally have some concerns about putting language access in the challenge pool, but that's just kind of my own thoughts, having a very deep understanding of this measure, and also agreeing with Leona and her comment about the fact that we pushed really hard on this measure for 2023 with a very high benchmark, which I think is great, but I think we need some data on how that worked out for the CCOs, which obviously we won't have for 2023, but at least we could have 2022 data potentially on the sample that was reported on from the CCOs, and maybe that would help provide some context, because I think there were some considerations there. So that's how I feel, but I think maybe if we have more data, we could have another conversation about it.
Yeah. The other one that was discussed though as well was the social and emotional health. So
I'd like to add one of the 2. I keep going back and forth just because of the feedback that everybody is giving. I don't want to eliminate meaningful access, but I hear the concerns, but I also want more information, just like Courtney was saying. But I don't know how many is too many to add to the to the pool to consider. I do think those high transformative ones, right? Like we had talked about adding one of those in. I do think if possible, could we narrow down, like let's pick one to consider, because there are a variety of ways to choose the challenge pool. And what I'm hearing is we haven't quite agreed what our method is and what we want to focus on. So I don't want to leave one of those out, because that would totally take out that method of choosing a challenge pool measures that are highly transformative. So I want to keep that in. I'm hesitant to add too many.
Yeah. So the top would be the social needs screening and referral, if I'm reading this right. Here's a transformative, followed by the ODHS custody, the assessments, the meaningful language, the social and emotional health.
It seems like it's too early for social determinants of health. Because we're still in phase 1, component 1. So I'm not sure that that's really promoting a whole lot there. And then we've heard, pros and cons for meaningful language. The DHS, I'm just really getting into the details of that one. June 1st, I'll know a lot more, but it sounds like there's some real challenges in there. I can't speak to that. That's what I'm just at the very surface level hearing about, even though it's clearly really getting at transformation at a young age, which is critical. So if I was forced to pick one today, I would go with socio-emotional health out of those 4. But recognizing that I don't know, again, coming back to Shamiko's point, like I just feel like there needs to be a little more information to really solidify. But if we had to pick one out of those 4, that's the one I would lean towards at this point.
Not to complicate all of this even more, but going off what Leona's saying, like, all right, so we have we're putting forward all the ones from last year. We're potentially adding the depression screening. And then could we add one more subset of saying, hey, we would like to consider at least one transformative measure, and these are the top 4. You know what I'm saying? Like, I know that's adding a lot, but if you kind of separate it out, it's not as confusing than just saying like, here's like half the measure set that we're considering. At least it breaks it down into kind of a thoughtful, but that might just be a little too much. I just feel like us having a discussion within 8 minutes about which one of these transformative measures we want to add is a big ask.
I hear that. At the same time, I get concerned about both us and the community having a lot of options to review and think through, and all of them are important. And what if we end up in the same spot where it's like, can we just have 10? And we can't, right? And so I hear you totally. I just I worry about that. I worry about being faced with too many choices, and then because we still would have to just choose one, and we could have the same discussion all over again next month.
So do we just
we'll know more information? We'll know more information maybe by then, but yeah. Sorry, go ahead, Courtney.
I was just gonna say, so do we select what we all voted on as being the most transformative? That feels like that makes a decision, or we retake the survey. I don't know. Now that we've had this conversation.
I feel like those numbers are just too close, and just kind of the way that survey was taken is not the most accurate way to say, yeah, those are definitively the most transformative. Jim saying, like, I feel like,
yeah,
this is a good place to base out of, but not a great place to say, yeah, that's definitely number 1, 2, 3, 4.
Yeah. Clearly we like these measures too much.
So there's potentially an idea on the table to everyone think through kind of how you would rank those top 4 transformative measures. send your top 4 ranking to OHA, to, I'm assuming Allison and Sarah. And then so basically we hold out, we postpone this. We do a draft of the challenge pool when we meet in June. We then give the community time to review, and then we finalize in July. So pushing this decision off after some more thinking on the challenge pool, as well as whatever data can be shared, at least the state, it sounds like the statewide data can be shared before we meet in June. I don't know the implications of that in terms of timeline, maybe not, just because we can still start with the benchmarking on the incentive measure set, I suppose. But we won't start that in June anyways, it'll be an orientation. So July meeting would start with finalizing the challenge pool and then jumping right into benchmarking for the measure set, correct, Sarah?
It would be, sorry, so the June meeting would be finalizing the full set, creating a draft challenge pool, and then starting your benchmark orientation. And then yes, July would be, you have to start that meeting with, you have to finalize the challenge pool and then start making benchmark decisions. And just, I guess, thinking about this for all of you, if you want to allow a month for public comment, you would have to get through all of your benchmark decisions with July and the August meeting before you would finalize in September.
So when do you all, Sarah, when I say you all, Sarah and OHA team, when can the statewide data be sent out to us to review?
I can send it a week before the June meeting.
Okay. Is there any other information or data that would be helpful for folks to kind of narrow down and figure out for the challenge pool, which are those transformative measures? Anything else that would be helpful?
Sarah, did you say whether or not that we could evaluate the immunization data based on the specs versus all kiddos who received, those kiddos that received their vaccine series, but not before the time frame?
I don't know yet. I sent an email to colleagues in the public health division who work on immunizations to see if that's something we'd be able to provide.
Okay, thank you so much. Oh, and I assume the preliminary data, statewide data that you can share with us in June will include the language access sample reporting that the CCOs did, right?
That I'm still confirming. I'll send an email out on that.
Okay, thank you.
And any other pieces of information or data that will be helpful to inform your decision? Community health needs assessment reports, anything like that?
Just a question. Did we finalize the benchmarks in November last year? And was that
we pushed it? Was that marathon?
Yeah.
We met for 6 hours.
Yes.
Just put on record. I don't want to do that again.
I don't either. That's kind of why I was wondering about the finalizing it by September. I'm just remembering how much time and discussion was needed. But OHA team, was November just like too late and it was a total scramble at the end of the year? And is that too late to notify CCOs and everyone? I'm just wondering how much room there is in September being the deadline for benchmarking.
So per contract, you technically have till the end of the year. November has been the latest it's ever been done. And I mean, I'm looking at the CCO representatives on the committee. That isn't what we hear from CCOs, is that is not ideal. Like, the CCOs want to know the benchmarks as soon as possible. And part of the reason the committee has done it historically, tried to finish the benchmark selection by August or September really being the target date, is because of a couple things. One, the availability of the data from the most recent report. So like what we're talking about, when we would have 2022 data for you all to look at that, like there's only a certain time when we actually have that, because we need to allow time for validation. So it's balancing that with like what we hear is CCOs want to know this as soon as possible.
Yeah. Okay, so we're right at 12. So this is what I'm hearing. We're going to postpone drafting the challenge pool set until next month when we meet. So Sarah and team will be sending out information and resources. Please be thinking about this in terms of how you want to try to narrow this down. And then at some point in time, eventually at one of these meetings, we'll get to talking about doing in-person meetings and how people feel about that and the structure of that. Anything else I'm missing, Sarah, in terms of announcements to kind of close things out? Thank you all again for your thoughtfulness and your hard work. We did accomplish, I think, a huge task today, which was drafting the overall incentive measure set for 2024 that now the public can respond to. Please socialize it. Get people to write comments or even come on and join us for public testimony. So again, thank you all so much for your effort and getting that piece accomplished today. Anything else, Sarah? No.
I don't think so. Thank you all.
Okay.
Thank
you,
everyone.
Everybody.
Thanks, everyone. Happy Friday. Bye.
Bye.
Thank you. Bye.